And I'm Walter Kernan. I'm a primary care physician at Yale School of Medicine, where I'm an emeritus professor of medicine. One of the main motivators for updating this guideline was the fact that there has been so many important advances in managing traditional cardiovascular risk factors. These advances mean that clinicians can be smarter and more effective in helping individual patients reduce their risk for stroke. In terms of hypertension, there is one major change in our guideline, which is to lower the target blood pressure goal from 140/90, which it was in 2014, the last time this guideline was developed, to less than 130/80. Otherwise, we still recommend regular screening for adults. We still recommend that most adults with hypertension will need two agents to bring them under control. And we do recommend home blood pressure monitoring for almost every patient with blood pressure. Now, the second traditional risk factor I'd like to discuss and point out is dyslipidemia. Since the 2014 guidelines, there are new therapeutic classes. Treatment of dyslipidemia is still based on estimate of risk for cardiovascular disease to select patients for therapy. But for patients who need therapy, we now have the PCSK9 inhibitors and we have bempedoic acid for those who cannot tolerate statins or who do not get to go on statin therapy. Now, we point out that there is not direct evidence that PCSK9 inhibitors or bempedoic acid reduces risk for stroke, but there's good reason to believe that they do this by lowering lipids. So we have more options to help people get to goal. Now, the third traditional risk factor I want to talk about is diabetes. Since 2014, there have been major advances in diabetes. In particular, there are now 3 drugs which both lower blood sugar and prevent cardiovascular disease. These 3 drugs have represented a revolution in diabetes care. But in particular, we point out in this guideline that for patients with diabetes who have either pre-existing cardiovascular disease or high risk for cardiovascular disease, as evidenced by dyslipidemia, diabetes, or chronic kidney disease, those patients now really should be on GLP-1 receptor agonist therapy like semaglutide. These GLP-1 receptor agonists, at least 2 of them, have been shown in these populations to reduce risk for cardiovascular disease. Now, none of these studies that tested these agents were designed specifically with a stroke outcome. However, in meta-analyses, the benefit for stroke reduction was greater than the risk for any other endpoint. So almost every patient with diabetes who's at high risk for stroke really needs to be on one of these agents.